Good afternoon, everybody. I'm Dr. Singh from Columbia, Missouri. I'm Chief of Nuclear Medicine, and I have been practicing nuclear medicine, nuclear cardiology for over 40 years. Our cardiac studies initially took a dive, and now we're very pleasantly surprised that they're going up. And that's nice because most of the places, U.S., these studies numbers are going down. So our department is very happy that not only the PET CTs growing exponentially, the nuclear cardiology and a whole lot of studies are growing, and so there must be something we're doing right. Our cardiologists are also very happy, and they like our service, and what they don't like is the studies done many places outside where they come with various artifacts and misinterpretations. And so they often ask me, what do you do differently? And we do everything we can to provide studies free of artifacts and interpret appropriately. Myocardial perfusion studies are one of the most common procedure in nuclear cardiology. However, the technique is highly vulnerable to pitfalls and artifacts. Understanding of the artifacts is very important to avoid misinterpretation. These defects may result from photon attenuation in patient with morbid obesity, patient with large breast, and from diaphragm. Patient motion is a very common cause of artifacts and pretty severe problem to deal with. High adjacent extracardiac GIT activities can also produce spurious defects. Suboptimal protocol for body habitus may lead to subquality study. Suboptimal SPECT technique and reconstruction can also give you problems. And image display has to be proper, otherwise you could be misinterpreting findings, whether it's reversible or fixed. And rarely artifacts occur from gamma camera malfunction. Our approach is that we do treadmill stress tests only if the patient is physically fit to exercise. If a patient has a handicap or a patient is not in a position to exercise well, the test isn't going to be any good. So we do regularness on Lexiscan in all of our patients. Every patient that comes to nuclear medicine, we select protocol based on body habits. Thallium is being rarely used because a lot of patients have morbid obesity and large breast, and also there's concern of radiation being higher than much others. The sestamine and tetraphosphine are less vulnerable to artifacts, and therefore that's what we are using these days. We provide one-day protocol and two-day protocol. One-day protocol involves doing resting study with 10 to 15 millicuries, followed by stress 30 to 35. And patients with severe morbid obesity, one-day protocol doesn't work well. So we do stress images first with 30 millicuries, followed by rest studies on the next day if there is abnormality on stress scan. Thallium is a very good agent. It's a potassium analog. It's transported across sarcolemma ATPase. Has very high first pass extraction, but it does give you high radiation dose to the patient. So the dose is limited to 3.5 millicuries. Other problem is the energy that we image is 69 to 81 kV, and because of low energy, it is more vulnerable to artifacts, and that's the reason for not using in patients with morbid obesity. Sestamine and tetraphosphine, excellent energy, doesn't get any better, less vulnerable to artifacts. We have additional benefit of getting LV function assessment and regional wall motion analysis that can help you provide better information. However, the extraction fraction for these agents is approximately 50% lower than thallium. However, since we give a large dose, that does compensate quite a bit for lower extraction of system AB and myoview. This is a kind of optimal study we have done. Here, stress image is displayed on the top, resting in the bottom. All the slices are lined up properly, and intensity is pretty well equal on both stress and rest images. This is a patient who had a normal body weight and BMI, and therefore image quality is good, and patient has infralateral ischemia. This is a patient with severe morbidity. Thallium images are pretty useless. You can see these are uninterpretable. The maybe images are relatively better, and there is clearly a defect here, but you can't really make any head and tail out of these resting images with thallium. This is a patient who's over 500 pounds and a 49-year-old man. In spite of the fact that he's big, we gave 35 millicuries, obtained images. These are excellent quality images and diagnostic. So we didn't need to do the resting images since stress was normal. Another morbidly obese patient, 481 pounds, we used 30 millicuries of tetraphosphamide for each study, and both studies are pretty decent, and there's a reversible defect here that is a real finding, and the patient had ischemia. This patient is even worse, has 600 pounds. Maybe we have more share of obese patients in our state, and this patient is 600 pounds, and you can't fit him into the gantry, so either you chance you have to do nothing or do planars. So we do planars, and time, oh, yes, okay. You got a good image here, and so it did provide useful information. The breast attenuating artifacts can be corrected, and that's documented in one of this paper here. Here's another patient where we have attenuation in the anterior wall due to breast, and on attenuation correction that normalizes. Another patient with the breast attenuation normalizes on correction, and so the attenuation does work in many patients. Here's the patient with the diaphragmatic attenuation, and the attenuation works very well. And this attenuation comes from the fact that the diaphragm, the interposes between the myocardium and the detector head. This paper showed that there's a lot of improvement in specificity and small improvement in sensitivity when it comes to attenuation correction. So it does work for a lot of patients. It doesn't work if there is a significant misregistration being inspected at CT data set. Even small misregistration can give you misleading results. So sometimes it makes images better, sometimes make it worse, and you can see why it will make worse if there is a misregistration. It's first better in male and not as female because of breast artifacts, which are difficult to correct because the position of breast tissue can change during examination. Patient motion, this much patient motion here, there's a big defect here, reversible defect. Another patient that we had had an artifact here that looks reversible, but we thought this was a motion artifact, so we got this patient. Motion algorithms for correction don't work very well in our experience. So we repeat it, and it's very nice. Ejection fraction also increased from 46 to 60%. So having repeating images is probably way to go in patient with severe motion. And here's another patient that has a motion. There's a defect here. These lines tell you that there is definitely motion. And okay, all right. Another example of motion artifacts resolving on repeat images. And another case here. Extracardiac activity can cause this abnormality that is improved on repeat imaging. Motion artifacts are very difficult to correct, and reacquisition is way to go. if patient is left the lab for defect here, one way is just get a CT scan, and if LAD looks normal, then this proves there's nothing wrong in that area. A pacemaker can cause you sweet abnormality, and so looking at chest X-ray will help. One of the detector head was not properly peaked by technologists, so we saw this defect here and we found it, then corrected it, and it's fine. The peak has to be properly placed. This is from literature. Similarly, detector head off and there's a defect here that resolves when it is properly peaked. And dose infiltration can give you heart effect. And I'm almost done. Okay, all right, I can quit. That's fine. Thank you. I'm told there's no more time. No, that's yours.
I think good lecture, nicely covered how to avoid the artifacts, which are very important, otherwise the reports can be wrong. We can have next lecture.
Yes. We now request the chairpersons to present the memento and certificate to Dr. Amalok Singh. I'll hold that for you.